Doctor, group 23 students.
I see, right? Absent group 10 and others group. Continue lecture. Instrumental diagnostics COPD. If signs of bronchial obstruction are depicted FV1 to FVC less than 0.7. A bronchodilation test is recommended to determine the degree of obstruction resolvability under the influence of bronchodilator drugs. In all patients with COPD, the use of pulse oximetry is recommended to assess hemoglobin oxygen saturation and exercise testing, such as a 6-minute walk test, or in some cases, bicycle ergometry is recommended to determine exercise tolerance in patients with COPD. In this slide, we can see spirometry. Spirometry measures the amount and rate of air a person breathes in hour to diagnose illness or determine progress in treatment. In the slide, we can see pulmonary function test, normal spirometry function test, and absolute. You can see FEV1 reduced, FEV1 FVC decreased, and PEF reduced. Bronchial obstruction severity classification according to in patients with FEV1 to FVC less than 70%, 15 minutes after 400 milligram microgram salbutamol. Stage 1, FEV1 more than 80%. Stage 2, FEV1 15 to 79%. Stage 3, FEV1 30 to 49%. Stage 4, FEV1 less than 30 minutes, in combination with chronic respiratory failure or right cardiac failure. Our diagnostic methods COPD. Arterial blood gas analysis is recommended for patients with chronic obstructive pulmonary disease with a pulse oximetry oxygen saturation less than um, 92% and research of partial pressure of carbon oxide. In patients with COPD under 45 years of age, in patients with repeat progression of COPD, or in the presence of emphysema, it is recommended to determine the level of alpha 1 antitrypsin in the blood. Classification of chronic obstructive pulmonary disease elucidation according to mild cause of the COPD, no respiratory distress, respiration rate 20 to 30 minutes, hypoxemia is corrected with mask oxygen, and treatment is short-acting bronchodilators. Moderate cause of the COPD, acute respiratory failure, respiratory rate more than 20 minutes, accessory musculature, hypoxemia is corrected with mask oxygen, increased partial pressure of carbon dioxide, 15 to 16 millimeters of mercury, and treatment short-acting bronchodilators plus antibiotics and or corticosteroids. Severe cure COPD, life-threatening respiratory failure, a respiratory rate more than 30 minutes, accessory musculature, change of site, hypoxemia is not corrected by mask oxygen, increase the partial pressure of carbon oxide, more than 60 millimeter of mercury, and acidosis. pH less than 7.25. And treatment recommendation hospitalization for these patients. Complications of the COPD are following: emphysema of the lungs, bronchiectasis, respiratory failure, pulmonary heart, pulmonary embolism, and maybe cardiac arrhythmias is polymorphic arterial tachycardia and atrial fibrillation. Attention please, all students. In this slide, we can see formulation of diagnosis COPD. First, the chronic obstructive pulmonary disease, and then the assessment follows. Severity: 1, maybe 2, 3, 4, violation of bronchial patency. Severity of clinic symptoms: pronounced CAT more than 10, MMC more than 2, not expressed, maybe CAT less than 10, MMC less than 2. And exacerbation rates rare, 0 to 1, frequent, more than 2. COPD phenotype, if possible. Complication, maybe respiratory failure, pulmonary hypertension, and etc. And concomitant disease with COPD. Treatment of chronic obstructive pulmonary disease. Treatment is based on age, overall health, extent of the disease, based response to treatments. Treatment of COPD are following: stop smoking, nutritional improvement, exercise, preventive vaccination against influenza, virus, strains, and recommended pneumococcal polysaccharide vaccine, early treatment of the infection, broad spectrum antibiotics, 7 to 10 days, and recommended bronchodilator drugs are following: methylxanthines, beta sympathomimetics, anticholinergic. and inhalated corticosteroid, and maybe recommended oxygen therapy. Components of COPD management. Are following: assessment and monitoring of the disease, a reduction of risk factors, treatment of stable COPD without intubation, patient education, drug treatment, bronchodilators, combination with inhalation corticosteroid and long-acting bronchodilators, phosphodiesterase for inhibitors, sulfilin, as well as influenza and pneumococcal vaccination. And recommended non-drug treatment, smoking cessation, pulmonary rehabilitation, oxygen therapy, respiratory support and surgery, and management of exacerbation of the COPD. Conservative treatment of the COPD. To give up smoking. Smoking cessation is recommended for all patients with COPD. Strength of recommendation A. Level of evidence 1. Very high level of evidence. Smoking cessation is the most effective intervention that has a major impact of the progression of COPD. Pharmacotherapy of tobacco smoking. Strength of recommendation A and level of evidence 1 very high. Pharmacotherapy effectively supports smoking cessation efforts. First-line drugs for the treatment of tobacco dependence, including varenicline, extended release bupropion, and nicotine substitutes. In this slide, you can see initial therapy for COPD groups according to Group A, recommended anticholinergic or beta-2 agonists. Group B, recommended a long-acting anticholinergic or beta-2 agonist. Group C, recommended prolonged anticholinergic, and Group D, prolonged anticholinergic plus beta-2 agonist, severe symptoms. Prolonged beta-2 agonist plus corticosteroid if eosinophilia more than 300 microliter and recommended ROF when you last. If CEV1 less than 15%, and if a patient smoker, recommended macrolides, antibiotics macrolides. Inhalation therapy could include anticholinergic, maybe next medicine, Spiriva, Respimant, Incrus, Siberian, and maybe beta-2 agonist plus anticholinergic. Maybe Anora and Ultibra. Those you can see those in the slide. Recommended inhalation one of the day. The inhalation therapy may be combination corticosteroid plus beta-2 agonist. For example, budesonide plus formoterol. Budesonide corticosteroid, formoterol beta-2 agonist prolonged effects. And you can see next medicines. Symbicort turbohaler, Symbicort repihaler, Toradil combi, Foster, Civitit multidisc, and maybe combination corticosteroid plus beta-2 agonist and anticholinergic. You can see these medicines this dose, and corticosteroid plus beta-2 agonist recommended 2 times the days of the days, and combination corticosteroid plus beta-2 agonist plus anticholinergic relevant improves once a day. You can see those. Indication and contraindication relation for corticosteroid therapy epidemiology. Indication are following: hospitalization with exacerbation of chronic obstructive pulmonary disease, more than 2 moderate exacerbations per year, more than 3,100 eosinophils per microliter of blood, associated asthma, and contraindication the inhalation corticosteroid therapy are following: repeated pneumonia, less than 2 eosinophils per microliter of blood, history of mycobacterial infection, treatment of exacerbation of COPD epidemiology are following: oxygen, non-invasive, invasive mechanical ventilation, bronchodilators is better to agonists, anticholinergics, inhaler, nebulizer, maybe oral corticosteroid, for example, prednisolone 20 to 40 milligram and methylprednisolone, or inhalation, for example, budesonide via nebulizer for 5 to 7 days. Antimycolytics: acetylcysteine and ambroxol. Antibacterial therapy epidemiology, patient in chronic obstructive pulmonary disease, The appointment of antibiotic therapy is recommended for patients with exacerbation of the COPD in the presence of increased dyspnea and increase in the volume and degree of prevalent symptom, or in the presence of two of the three listed signs. And the strength of recommendation B, level of evidence 2. As first-line antibacterial drugs for patients with severe exacerbation of COPD and risk factors, age more than 65 years, and recommended amoxicillin, clavonate, or respiratory fluoroquinolones, for example, levofloxacin or moxifloxacin, macrolides are recommended. And strength of recommendation B, level of evidence 2. Oxygen therapy according to oxygen therapy, hypoxemia, causes of serious threat of the patient's life. Therefore, oxygen therapy is a priority in the treatment of acute respiratory failure in the presence of the COPD. Strength of recommendation B, level of evidence 2. Rehabilitation of the patient with chronic obstructive pulmonary disease are following. The effects of pulmonary rehabilitation include improving exercise tolerance, reducing the feeling of shortness of breath, improving the quality of the related health, reducing the number and duration of hospitalizations, reducing the level of concern and depression associated with COPD, improved survival, improving hospitalization outcomes by about exacerbation, strengthening the action of the long-acting bronchodilator. Rehabilitation is a multi-component measure. It is recommended to include psychological support and the fight against depression in the pulmonary rehabilitation programs, training, nutritional support, and physical training. The duration of such a program has not been established, but it is believed that it can last from 4 to 10 weeks. Patient education, it is recommended that patient education be included in a pulmonary rehabilitation program for COPD. When educating patients with COPD, it is recommended that an mm, uh, individual written plan of action drawn up the self-help. Dispensary observation. The frequency of observation is 3 times a year. Examination by specialists, otolaryngologist, dentist once a year, physiatric, physiatrician, oncologist according to indications. The following studies are being carried out: general clinical blood test, sputum analysis, general spirography with drug tests, general clinical urine analysis, chest X-ray, maybe fluorography and X-ray, chest X-ray, electrocardiography once a year, sputum culture with determination of the sensitivity of the pathogen to antibiotics, important bronchodilators, cough medicines, physiotherapy, breathing exercise, oxygen therapy, and others. In prevention, early diagnosis of the disease and elimination of risk factors, to give up smoking, professional orientation of patients in cases uh, where work is associated with aggressive effects on the respiratory system during the period of stable course of COPD, and for prophylaxis, antibiotic therapy is not carried out. The number of exacerbations associated with infection disease can be reduced by vaccination. Prophylactic vaccination is indicated in usually for patients with mild to moderate severity of COPD with the frequency of infectious uh, relates more than 2 times a year. All oral multivalent bacterial vaccines, for example, ribomonil, bronchomonal, and locally. Rehabilitation therapy is prescribed for COPD of any severity. The doctor determines an individual rehabilitation program for each patient, depending on the severity, phase of the disease, and the degree of compensation of the respiratory and cardiovascular system. The program included exercise therapy, physiotherapy, spa treatment. And conclusion, the medical and social significance of COPD are conclusive. In this regard, it is necessary to know the basic information about COPD, data presented in learning journal and monographs. Implementation of clinical guidelines in the everyday practice of the therapist or general practitioner makes it possible to unify of the effects treatment of patient with COPD. In the slide, you can see literature, guidelines, Who student have a question to me? Group 10.
Yes, madam.
Who is student present, group 10?
Madam, I'm present. Jehani.
Tomorrow, group 10, you have topic of the polyclinic therapy. I sent you information about your lesson.
Madam, where did you send it?
Evening, I sent you information.
Okay, madam.
На почту.
Okay, madam.
Who is,
Thank you so much.
who student have a question to me? Our lesson is over. Is over. Bye bye. Good luck. Good luck.
До свидания.